very strong relationship between plasma cholesterol and coronary heart disease is now beyond dispute. But the time has come when we have to acknowledge that cholesterol alone cannot explain all aspects of atherogenesis. There are now several major international studies that show that one specific group of individuals has a particularly high incidence of coronary heart disease. These individuals are characterised not so much by a marked elevation of total cholesterol, but by the combination of a raised level of plasma triglyceride and low concentration of cholesterol in HDL, or high-density lipoproteins. Why is this pattern of dyslipidemia associated with high coronary risk? The presentation you're about to see demonstrates how triglycerides and HDL have added a new dimension to our understanding of atherogenesis. After all, our interest in the physiology of lipids is not just academic. It also has immediate relevance for everyday medical practice. It is now well recognised that triglycerides, HDL and total cholesterol should be measured simultaneously to assess a patient's coronary risk. The model described in this presentation helps explain why this is so.
Since cholesterol was identified as a crucial risk factor for coronary heart disease, attention has focused on the liver as a source of plasma cholesterol. It is now well established that once cholesterol is in plasma, it may accumulate in arterial walls to form atheromatous plaques. Because cholesterol is synthesized by the liver, that site has also been an important target for drug therapy to reduce plasma cholesterol. The group of cholesterol-lowering agents, known as the HMG-CoA reductase inhibitors, act by inhibiting the hepatic synthesis of cholesterol. However, the liver is not the only source of cholesterol for the atherogenic process. Cholesterol is also able to enter the circulation from the peripheral tissues. It is an essential biomolecule synthesized by all cells in the body for diverse purposes. For example, cholesterol is used in the synthesis of cell walls, steroid hormones, and bile acids. But although all cells can make their own cholesterol, most cannot degrade it. A mechanism is required to transport excess cholesterol made in the peripheral tissues to the liver, where it can be degraded or excreted in the bile. If there were no such mechanism, cholesterol would build up in the tissues with fatal consequences. The lipid pathway responsible for this is called reverse cholesterol transport. It carries cholesterol from the tissues through the circulation to the liver, where it is either excreted or recycled. Since cholesterol itself is insoluble in plasma, it must be carried through plasma in a water-soluble form. In the reverse cholesterol transport pathway, this is achieved by high-density lipoprotein particles, or HDL. Insoluble cholesterol is carried in the core of the HDL particle, while the polar surface coat of the particle ensures its solubility in plasma. It is now well established that HDL is not atherogenic. Measuring HDL cholesterol gives us a window into the reverse cholesterol transport pathway. The inverse relationship between plasma HDL cholesterol and coronary risk has led to the belief that a high concentration of HDL is protective against CHD and that a low concentration is harmful. Low HDL was thought to be harmful by virtue of a decreased capacity to remove cholesterol from the arterial walls in the first step of reverse cholesterol transport. Evidence now favours an alternative explanation. It now appears more likely that under certain conditions, cholesterol can be diverted out of the reverse cholesterol transport pathway and into atherogenic particles, leaving HDL depleted. To understand how this comes about, we must turn to another plasma lipid fraction, triglyceride. Because triglyceride is also insoluble in plasma, it too must be carried in water-soluble particles. One of the principal particles responsible for carrying triglyceride is very low-density lipoprotein, or VLDL. Human plasma also contains an enzyme which catalyzes the exchange of lipids between lipoproteins. This is cholesterol ester transfer protein, or CETP. When plasma triglyceride concentration is raised, this enzyme transfers cholesterol from HDL to VLDL. This effect is seen even when plasma triglyceride is only mildly raised. In clinical practice, this might be indicated by a fasting triglyceride level greater than 2.3 millimoles per litre, as shown in the prospective cardiovascular Munster, or PROCAM study. Cholesterol transferred from HDL to VLDL is then committed to follow the metabolic pathway of VLDL. VLDL itself is not atherogenic, but it is catabolized to intermediate density lipoprotein, or IDL. Some IDL is cleared by the liver, and some may also be further metabolized to low-density lipoprotein, LDL. Both these particles, IDL and LDL, are considered to be atherogenic. Ultimately, therefore, cholesterol, which originates in the peripheral tissues and is carried in a pathway not directly contributing to atherogenesis, may be diverted into particles which are atherogenic. After cholesterol is diverted out of HDL and into VLDL, cholesterol-depleted HDL is metabolized to smaller, denser particles. The end result is depletion of HDL and low levels of HDL cholesterol. The suggestion that high HDL protects against CHD and low HDL is harmful is thus too simplistic. According to this model, it is apparent that HDL concentration is a marker of this process rather than a direct cause of it. In other words, low HDL is a consequence rather than a cause of a metabolic process which is atherogenic. In clinical practice, this could be indicated by HDL cholesterol levels lower than 0.9 millimoles per litre, as shown in the PROCAM study. The model just described is one explanation for why the finding of raised triglycerides in combination with low HDL in a patient should alert the clinician to an underlying atherogenic process. It also helps explain the inverse relationship often observed between plasma triglyceride and HDL levels. Though neither HDL nor triglycerides are themselves atherogenic, the pattern of raised triglycerides and low HDL is a signal of a metabolic process that is atherogenic. The model we've just seen described also helps explain why a pattern of raised triglycerides and low HDL is associated with an increased risk of coronary heart disease in human populations. This has been demonstrated by powerful epidemiological studies, such as the Framingham study in the United States and the PROCAM study in Germany. The PROCAM study showed that plasma triglyceride above 2.3 millimoles per litre combined with HDL cholesterol below 0.9 millimoles per litre conferred a very high risk of CHD on individuals with a ratio of total to HDL cholesterol greater than 5. Most importantly, This model also helps explain how the regulation of triglycerides and HDL can help bring about a reduction in coronary risk. The Finns, who are plagued by one of the highest rates of coronary heart disease in the world, have contributed one of the most important clinical trials to shed light on this question, the Helsinki Heart Study. This placebo-controlled trial investigated the effects of the fibric acid derivative gemfibrozil on the incidence of coronary heart disease in more than 2,000 middle-aged men with dyslipidemia. Over the 5 years of the study, the group treated with gemfibrozil suffered 34% fewer cardiac endpoints than those receiving placebo. On average, their cholesterol levels fell by 11%, triglycerides fell by 35%, and HDL cholesterol increased by 10% compared to placebo. A subgroup analysis of this study has revealed that among these dyslipidemic males, those with the highest risk belong to the group with an LDL to HDL cholesterol ratio greater than 5, combined with a triglyceride level greater than 2.3 millimoles per litre. Although patients with this lipid profile comprised only 7% of the total study population, they accounted for 22% of CHD events. Treatment with gemfibrozil reduced the incidence of CHD events by more than 70% in patients in this group. Gemfibrozil is thought to achieve its effects on the lipid profile by reducing the synthesis and increasing the clearance of VLDL particles. It therefore reduces the concentration of plasma triglycerides. This in turn reduces the transfer of cholesterol from HDL into VLDL and reduces the accumulation of cholesterol in unwanted atherogenic particles. Another consequence is the elevation of HDL cholesterol levels.
As you have just seen, cholesterol, triglycerides and HDL can all contribute to the process of atherogenesis. This model offers us a physiological insight into why the combination of raised triglycerides and low HDL is such a strong predictor of coronary heart disease. Although much work still needs to be done to uncover the whole story of atherogenesis, this model also emphasises the need for a multi-lipid approach to the diagnosis and treatment of dyslipidemia.